Tuesday, December 8, 2020. Welcome to the online ART training in Module 1B on Sperm Morphology. It is 9 a.m. Eastern Standard Time. My name is Ashok Agarwal, and I am going to be your host for the next 2 hours. We are here in Cleveland Clinic in Cleveland, Ohio, United States. Just a very short introduction to myself. I am the head of Andrology Laboratory at the Cleveland Clinic Foundation in Cleveland, Ohio for past 28 years. I'm also the director of the American Center for Reproductive Medicine. I'm a staff in urology at Cleveland Clinic. And I'm very proud that our team is rated as #1 in the world in the fields of male infertility, andrology, and human-assisted reproduction. This is based on the number of peer-reviewed publications, citation scores of people who are using our articles into their own publications, and an H-index. These together can be searched by anybody in any part of the world using Scopus. We have a large number of books in the area of human reproduction, and many more books are going to be coming in. And our laboratory has trained a very large number of scientists, clinicians, and graduates and undergraduates from the United States and more than 85 countries. So with these words, I want to welcome all of you who are attending the program. We are expecting a number of about 1,400, some numbers, and I think you will see in the slide who have registered. The capacity of WebEx platform, which is being used to air this program and reach out to all of you, is 1,000. Those who are not able to get in and who join a little bit late will be able to see this program live via the streaming link which has been provided on the WhatsApp. For declaration, the organizers and the speakers have no conflict of interest. No companies or outside entities were contacted for sponsorship. The program was made entirely possible by support from the Cleveland Clinic. Webcasting was supported by our colleagues David Reichling and David Wolfley from IT, who have generously supported our program last month as well. The course faculty have generously donated their time for this online training and have spent pretty much the entire 1 month preparing for this course, as you will hear. Program coordinators, we have a fantastic team of 9 coordinators from all different parts of the world who have generously donated a large amount of their time on a day-to-day basis for this training. The names, images, and description of certain products or instruments shown or discussed during the lectures in today's presentation are being used routinely by us in the Andrology lab. These items are not endorsed by any of us as speakers. So let's talk very briefly. The learning objectives of today's module is to develop an understanding of sperm morphology by WHO 5th edition, understand the staining protocol used in the laboratory, learn the use of strict criteria classification, understand the external quality control in sperm morphology, learn about, and there are many troubleshooting tips that we are going to. Professor Henkel is a visiting reader in the Department of Metabolism and Digestion in the Imperial College in London. He has moved there very recently. He is also the chief scientific advisor at a company called Logix Pharma in Reading. And he is an extraordinary, actually, he is an extraordinary man and extraordinary professor of reproductive biology at Western Cape University in South Africa, where he was for past, I believe, close to 20 years before he moved from Germany. His wife is from South Africa. Professor Henkel, more importantly, is an editor-in-chief of Andrology, one of the most prestigious and original journal in the field of andrology. He is a highly decorated andrologist of great stature and a very humble man and a great friend of our program. We have been collaborating actively for the last number of years, and he has been visiting us for the summer every year since of the COVID. He could not visit, but hopefully next year he will be here. So
good morning, good afternoon, good evening, everybody, wherever you are. My name is Ralf Henkel, and I'm Chief Scientific Advisor to Logix Pharma in Reading in the UK, and I also hold a visiting readership at the Imperial College London. I present my presentation on importance of strict criteria and assisted reproduction. The learning objectives of this lecture is to understand the value of sperm morphology in the diagnostic workup of infertile men, to learn about the WHO 5th edition reference ranges for normal morphological forms of spermatozoa, understand the pros and cons in the relationship between strict criteria and assisted reproduction, as well as to recognize current consensus on the clinical value of sperm morphology. If we talk about fertilization, we must first understand that this whole process is a multifactorial process, and on the side of the spermatozoa, all these different functions of the sperm play a significant role, and if one of these functions is low ranged, then this will lead to poor fertilization and pregnancy failure. Morphology, which is here, plays one part of this whole cascade of different sperm functions, and it is associated with these other different sperm functions. But where does this concept of normal sperm morphology come from? If we look at the cervical mucus, both sperm that we can find in there and at spermatozoa that are bound to the zona pellucida here on the right hand side, these sperm that can be found there led actually Professor Menkveld from Tygerberg Hospital in South Africa to the idea to investigate what is happening there. And looking at specifically at the zona pellucida is binding normally formed sperm. It has a specific binding capacity, whereas not normally formed sperm will not bind. And all this background led him to develop this concept of strict morphological criteria for spermatozoa with clear definition of sizes and the morphometry. He was then further developing this whole concept, and this will be discussed and presented in a following lecture. But at this stage, I just want to say that all these different criteria have to be met to actually count a spermatozoon as normal. But what does it mean, and what importance does a normally formed spermatozoon has? If we look at the sperm morphology, if it is impaired, it can give an indication of possible abnormal genetic condition. And here I just want to mention globozoospermia, that is spermatozoa that have a sperm head which is round like a football and not overly shaped. This is indicating of a genetic abnormality. Then we have, for instance, small acrosomes, like here, this indicates that these sperm are dead, they are not viable. On the other hand, here these elongated sperm heads, they are an indication that patient has a varicocele, which can then be medically treated. On the other hand, normal sperm morphology is not dependent on the abstinence, whereas other parameters such as ejaculatory volume or sperm count or even DNA fragmentation, they are related to the abstinence period. So in general, we can then say that normal sperm morphology indicates the male fertilizing potential and gives a probability of fertilization and pregnancy after spontaneous and assisted reproduction outcome. It will also give you a need of further treatment of specific patients and the possible techniques that can then be used in the embryological lab. But where does this all come from, and how did it actually develop over the time? If we look at the history and see from the WHO, which developed and published different guidelines as from 1980, and what there was the first guideline published, and the latest now was in 2010, the fifth guideline. What we can see specifically for morphology, the cutoff values dropped dramatically from 80.5% to currently 4%. The question is, why did the sperm morphology, or did the quality of male sperm decline so dramatically, or what happened there? If we look closer, we see that in the first editions of the WHO manual, there was a liberal approach, and it was more like observations that took place. Then in the early 1990s, Menkfeld introduced the strict criteria, which was then based on the normal forms that were found at the zona pellucida and in the cervical mucus. Later, in the 1999 edition of the manual, it dropped to 14%. Oops. And this was due to what was seen in the fertilization in the IVF program. And finally, the last drop to 4%. This is simply due to WHO moving from cutoff values to these lower reference values. And what we see here over the period of time, it was a significant decrease in so-called normal sperm morphology. And people then ask the question, where does it come from? What are the reasons for this to happen? And initially they thought there's a negative environmental influence. What we can see, there's overall, there's also a decline in male fertility, yes, but here in this study by Ariagno, where they analyzed or reanalyzed the slides and studies from all these years, where they found the drop in morphology, yes, but after reanalyzing, there was no change. So one can conclude that this drop, what we can see here, is simply due to implementation of strict criteria and adherence to it, and sometimes also overcritical evaluation, or even that some more abnormalities were identified because people were more interested in morphology and they looked more closer to what was happening there. So, and eventually it was a more evidence-based approach that also contributed to this decrease. What we can see with regard to the impact of morphology is that there's a highly significant impact on fertilization. Patients with high morphology rates, here with more than 4%, they have higher fertilization rate than those patients with low morphology. And further, there's also been considerations that, and papers published that say morphology doesn't play such a role. So in the following slides, I want to highlight and throw some light on all these pros, where people say morphology has a predictive value and is based on evidence-based data, and also on the cons, which is we must understand the pros and cons. So the studies were published where morphology has poor or no predictive value, and they also show evidence. Let's start with the pros for morphology. What we can see here in these studies here by Kruger et al., he could clearly show that there was a significant relationship with higher fertilization rates in patients with higher normal morphology. And that was here the cutoff of 14%. In a subsequent study, he further analyzed this group that had lower fertilization rate, less than 14%, and found there's two groups with those between 5% and 14%, which had a fertilization rate which was close to what was observed in patients higher with fertilization, with pregnant, with morphology rates higher than 14%, and those that had morphology rates less than 5%, which has then poor fertilization rates. And this was then called a P pattern for poor morphology pattern and G pattern for good morphology pattern. If we look further here in a study by Nginzu, including 200 patients, these authors could also clearly show a significant relationship between normal sperm morphology, here as a correlation coefficient that was really significant, with 14%, the conventional cutoff value, and the strict criteria. And if we look at this strict criteria here at the bottom, we can see this relationship in terms of the correlation coefficient is significantly better than that for the 14%. And here also the likelihood ratio for the onset of a pregnancy is much higher than for the 14%. In a further study, Obara et al. Also showed a highly significant positive correlation between normal morphology and fertilization rate. And they confirmed those data previously published by Kruger et al. The higher fertilization rates were observed in patients with normal sperm morphology when compared with those with good prognosis pattern and poor prognosis pattern, where basically no fertilization took place. So summarizing these takeaways for the pro side, we can say that sperm morphology evaluation using the strict criteria is a good predictor of in vitro fertilization, and with these criteria, we can also select couples who may benefit from intrauterine insemination. On the other hand, strict criteria also offer a reliable estimation of fertilizing ability of human spermatozoa. On the other hand, those more recent studies, they are rather critical to the implementation of strict criteria and morphology at all. Here I show a study by Hoterling 2001. These authors included more than 2,800 IVF and ICSI cycles with quite a number of teratozoospermic patients, and with the exception of this study here by Dubey et al. Of 2008, the odds ratios here do not look great. And as a consequence, Hoterling et al. Concluded that sperm morphology is not a good predictor of fertilization after assisted reproduction. In another study, Van den Hoven, 2015, basically confirmed this in a separate investigations for IVF and ICSI, and for morphology, there was basically no significant relationship for pregnancy, ongoing pregnancy, and abortion, and only here for the total progressive motile sperm count after ICSI, that was a bit significant, and here also for normal morphology. But if you look at the odds ratio, they are not great. So these authors then also concluded that sperm morphology has poor or no prognostic value for the pregnancy outcome after IVF or ICSI. In a third study, also including more than 1,000 ICSI cycles, these authors, French et al. 2008, compared the clinical pregnancy rates in patients with different levels of normal morphology. For here, clinical pregnancy rate, there is basically no change. The implantation rate, this light blue bars, basically no change. And the live birth rate, there was also no change. So also these authors also concluded that morphology, even using strict criteria, had no or little prognostic value, specifically in this case after ICSI. So here the main takeaway message is that if we look at the cutoff, the evolution of sperm morphology led to the lower cutoff values has decreased the predictive power. Well, these studies have also limitations because they are quite heterogeneous groups of studies. There is different staining methods was used. Some groups use the Papanicolaou, other groups use the DIFQuick. Next group was also using the aniline blue stain. All these are factors that have to be looked at. If we specifically look at ICSI, the use of one single sperm selected by the embryologist, which is then injected into the oocyte, actually bypasses all natural selection processes, and therefore morphology seems to have no impact, except in the end the DNA that must then be normal, and there must be normal DNA integrity. But with regard to possible birth defects in ICSI, there are still more studies are necessary to examine this association between possible birth defects, birth outcome, and the impact of sperm morphology. So summarizing this evidence that is there and comparing it, on the pro side, there was studies that showed a clear, strong association of morphology with fertilization, whereas morphology together with the progressive motile sperm count helped with the selection of the patients to guide them into either IUI, IVF or ICSI, and certain abnormalities can give then the clinician an indication what the reason for the infertility is. And of course, we have to look at the method how the morphology is determined, so it must be done correctly in strict adherence to the WHO criteria. On the other hand, on the con side, whereas clearly studies show a lack of consensus, whereas current studies have many shortcomings, there's low predictive value for IVF and ICSI, and this is because ICSI bypasses all natural selection barriers. But if we compare normal spermatozoa versus an abnormal spermatozoon, normal sperm morphology, it only reflects normal spermatogenesis in the testis and normal epithelial maturation. And it also relates to likely functional potential, but does not necessarily equate to fertilizing ability. And the emphasis here is on likely. On the other hand, morphologically abnormal sperm can, and they do, fertilize oocytes. And there we still have to understand the female genital tract and the mechanisms, how the female genital tract selects sperm, much more than we do at the moment. So the take-home message of this presentation is that strict criteria classification is based on the concept of natural selection at the zona pellucida and the cervical mucus, and it can predict fertilization ability. It gives an indication of the underlying pathology and thereby assisting the clinician to guide the patient. It can also be used as a tool to choose the type of assisted reproduction technology in the laboratory to guide the patient so that they have the better success. And therefore, this cutoff here with a lower reference value of 4%, if it is higher, then the patient can go for IUI or IVF. If it is lower, then the patient should rather go for ICSI. Also, the standardized morphological assessment by strict criteria continues to remain relevant, although there is the contrary concepts in saying there is no impact of normal sperm morphology for fertilization outcome. It still helps guiding the patient and making clinical decisions. And with this, I want to thank you very much for your attention. And this are some slides on my repeated visits to Cleveland. And this is Hammersmith Hospital, where I am based in London at the moment.
This is our group at Cleveland Clinic in Andrology Center. And this is one of the images of the Cleveland Clinic. And you can connect with our program. We are posting daily our research activities, large number of research articles. You have free access to all these publications that we are offering. We are also sharing our latest research presented at ACRM, which is American Society for Reproductive Medicine, European Society for Human Reproduction, American Urological Association. Also, you can learn about our research opportunities and ART training, which are online ART training and opportunities to collaborate. You just have to find me on LinkedIn, Ashok Agarwal Cleveland Clinic, and you can send a request to join.